We're very excited today to be joining you from the Indiana University Center for Diabetes and Metabolic Diseases. It's my distinct pleasure to introduce you to Dr. Carmela Evans-Molina. She's an MD, PhD, and she's the director for the Center for Diabetes and Metabolic Diseases at Indiana University Center for Diabetes, Metabolic Diseases. And she is going to just sort of give a little bit of an intro here. The title of the talk is Diabetes Moonshots, Changing the Course of Diabetes, of Type 1 Diabetes. And the discussion is really going to center around the key role that Indiana University is playing in the development of biomarkers and implementation of screening for type 1 diabetes. And additionally, how IU is really deeply committed to understanding the pathology of type 1 diabetes, along with lines of current or inquiry currently underway at the university. It's a great way to learn more about why IU is a powerhouse of type 1 diabetes research and clinical translation, informing your next career steps and collaborations. Welcome to everyone joining us from IU, and we will, I'll let Carmela talk a little bit about the center, and then I will introduce people one by one, but just a little bio about her before she starts speaking. Dr. Evans-Molina joined the faculty at Indiana University School of Medicine in 2008, where she's the Eli Lilly Foundation Professor of Pediatric Diabetes. She serves as the director of the NIH P30 funded Indiana Diabetes Research Center and as director of the IDRC, Islet and Physiology Core. She directs the Diabetes Research Program in the Herman B. Wells Center for Pediatric Research, and she's a staff physician at the Richard L. Rudbush VA Medical Center. She also serves as an associate director of the Medical Scientist Training Program at IU and co-director of the Diabetes and Obesity T32 training program. She's an investigator in the T1D TrialNet network, where she serves as scientific advisor, chair of the long-term investigative follow-up LIFT study, and chair of the TN31 Jackpot T1D trial. She's also a member of the Rare and Atypical Diabetes Radiant Network, and she's the co-executive director of the Network for Pancreatic Organ Donors and Diabetes NPOD, and a co-PI of the NIH-funded Integrated Islet Distribution Program, or IIDP. Her research is funded by the NIH, the VA, JDRF, or Breakthrough T1D, and Helmsley Charitable Trust. And she's also an associate editor for the Journal Diabetes. Incredible contributions to the type 1 diabetes research space. Thank you so much for joining us, and we're pleased to have you. Happy to listen as you walk us through what's going on at Indiana University right now.
Great. Thank you, Monica. And thanks, everybody, and welcome. I'm coming to you from Indianapolis, Indiana in the U.S., and I want to tell you a little bit about our Diabetes Center. Monica gave some introduction to it in those starting remarks. But as Monica mentioned, we are an NIH P30 funded diabetes research center. So we're one of 18 of these diabetes research centers funded by the NIH in the US. You can see the locations of the other ones here on this map. And you're going to hear in our site visit from a number of different investigators in our Diabetes Research Center. I wanted to give you a bit of an overview of the structure of our center and some of our research interests and themes that are really relevant to the mission of the sugar science, which is to foster collaboration and to cultivate the type 1 diabetes research community. So our Diabetes Research Center includes about 110 faculty from 10 institutions across Indiana. You can see the names of the institutions there in the slide. Our mission is really to promote cutting edge research, to foster collaboration and support training. And we do this through a number of different initiatives. The main focus of our Diabetes Research Center, that engine that really drives innovation, are our research cores, and we have 4 of them. An Islet and Physiology core. We have a lot of islet biologists here at IU, and you're going to hear from many of them during our site visit. We have a translation core that's focused on helping people do human research, an optical microscopy core run by Dr. Linneman, who you'll hear from in the panel discussion following this, and then our data and analytics core, which is focused on both informatics and computational approaches. We provide a lot of seed funding to help people who are newly starting their career or people who are trying to develop a new idea in diabetes. So this is done through P&F awards and then smaller core box initiatives that help them interface with our cores. We have a really robust enrichment program that includes a weekly seminar series, an annual Diabetes Day Symposium in August every year, and then special lectures, including one for World Diabetes Day. And then an important focus of our mission in the center is to promote collaboration. And we take this to mean supporting collaboration between the center members, helping members connect with members of the national and international research community, and then helping our investigators connect with other disease areas. And we've been, I think, particularly successful in doing this and building bridges with our Alzheimer's focused researchers here at IU, as well as our musculoskeletal health researchers here at IU. And then also we like to support collaboration and interaction with industry and biotech. And then finally, we're really focused on training and career development. We have a big focus on early career investigators, including leadership in really important training programs like the DiabDocs training program, which is a wildly successful K-12 program led by Dr. DeMeglio and Dr. Moz at Stanford University. And then we have a big focus on students and postdocs, and you'll hear from some of our students and postdocs as part of our site visit today. Now, Monica mentioned that we have kind of a new location. So in August, we moved our Diabetes Research Center and several of our labs to the 16 Tech Innovation District in Indianapolis. You can see some pictures of our new space here. This has been, it was a big lift to move eight labs and 9 different research groups, but it's been great. And I think it positions our center well in this 16 Tech Innovation District, where there's a nice focus on interacting with industry and biotech. And I think an example of this is a really exciting announcement made by the university yesterday that's centered on the creation of something called the IU Lab, which is an accelerator for bioscience in Indiana that will focus on talent development as well as collaborations between academic partners and industry in Indianapolis. Our investigators are grouped into 4 different thematic themes, including individuals who are focused on cellular and molecular metabolism, complications, islet function and survival, and the nutrition and physiology of diabetes and obesity. And again, you can see the locations of our 110 faculty members throughout different institutions in Indiana. Now, I think what's great about this site visit is that you can stop hearing from me and you can hear from the incredible investigators in our center. And you're going to do that through 3 different formats. So we're going to have this panel discussion that's immediately following this introduction. That's going to include 4 investigators in our center. And I think Monica's going to introduce them right before the panel. They're going to focus on really what are we doing here at IU to change the course of type 1 diabetes. And then you're going to also hear via recorded presentations from early and mid-career CDMD investigators, shown here, Dr. Kai, Ismail, Temple, and Felton. And then we're really happy to highlight work of our trainees, including 2 MSTP students, Matt Austin and Maddie McLaughlin, and then a postdoc, Chaitra Rao. Now, the sugar science is focused on type 1 diabetes, and that's a major focus of the research that we do here in our Diabetes Research Center. And we like to envision the work that we do across 5 different pillars. And if you think about the research that I'm going to talk about, it's really progressing along a translational continuum. And our first pillar is really basic science. So how do we understand the molecular pathways that contribute to type 1 diabetes? And this leads nicely into a focus that we've had in our center and our institution on biomarker development. So we feel like this is a real translation between the basic science and the clinical research that we're doing in the center. And we have a really active biorepository and sample collection system set up here at IU to try to develop biomarkers that can help us with type 1 diabetes risk prediction. And then we think that these biomarkers have a real integral role in clinical trials. And we're very interested in trials to preserve beta cell function in type 1 diabetes. We do work in networks like TrialNet, the ITN, and then we have a lot of investigator-initiated trials and initiatives too, like the Tadpole trial led by Dr. Sims, and I think you'll probably hear about that in the panel. And then our 4th pillar is really how do we take all this information and identify individuals who are at risk of type 1 diabetes so that we can offer them either different care or the opportunity to participate in a prevention therapy. And then finally, how does this all come together? Really, our major focus is improving the care of individuals who are either at risk of developing type 1 diabetes or who have type 1 diabetes. And I think you'll hear about how these pillars fit into the research that is going to be focused and discussed from our center. Now, ultimately, I said what we envision as our most important mission here at IU is to improve the care of individuals who are at risk of developing diabetes or have type 1 diabetes. And so I just want to also really highlight innovative care models that we've developed here at IU. We have one of the first in the country efforts to offer care to individuals at risk of type 1 diabetes in an at-risk clinic. And this is an initiative led by Dr. Jamie Felton. And you can see the first young child in Indiana who was treated with teplizumab in stage 2 type 1 diabetes. Dr. Felton and her team have gone on to treat a number of other children who are in stage 2 type 1 diabetes to see if they can delay the onset of clinical diagnosis. And our team was featured by the Indianapolis Business Journal as one of the 2024 healthcare heroes for this initiative. Now, none of this would be possible without a lot of dedicated funders and partners that we have nationally and within Indiana. And so you can see different foundations that have contributed to our research here, as well as different funding agencies. So we're really incredibly appreciative of the support that we get locally, nationally, and internationally to run our Diabetes Research Center. And then finally, all this helps us contribute to lots of different networks and national and international initiatives. And so we're really proud that our IU investigators are leaders in lots of different initiatives, including TrialNet, TEDdy, ITN, MPOD, Radiant, and others. And so I just want to finish by saying thank you to Monica and her team for featuring our Diabetes Research Center. We're really pleased to have you as part of the conversation in type 1 diabetes, and so appreciative of all the effort that that you do to cultivate collaboration, support trainees, and to really feature some of the research that we're doing to end this disease. And with that, I will turn it over to Monica, and we're going to do a small switch. Dr. Sims is going to join the panel from this seat, and then we have our other panelists in the conference room right next to me, but I'll let Monica go ahead and introduce them. And Monica, do you want me to stop sharing or leave the pictures up while you're introducing?
That'd be great to leave them up. Thanks so
Okay.
much for that nice shout out to us. And as you know, and as most people know who follow the sugar science, you know, IUMC is now incredibly well funded, state of the art, and just has a team of incredibly talented medical and basic science physicians and scientist physicians. And that's why we're constantly and consistently sort of noting that IUMC is truly a powerhouse. So let's introduce some of these the players here. Let's start with Dr. Emily Sims. She is a pediatric endocrinologist at Riley Hospital for Children and a physician scientist at the IU Center for Diabetes and Metabolic Diseases, as well as the Herman B. Wells Center for Pediatric Research. Her research passion lies in identifying and understanding risk factors predisposing susceptible individuals to diabetes development with an ultimate goal of improved risk prediction and development of novel treatments to predict or slow progression of diabetes. Then next to her is Dr. Linda D'Amelio. She's an MD, MPH, and a little bit about her. After graduating from Harvard University with honors, she obtained her MD from UPenn and performed her residency at Northwestern in Chicago. She completed her fellowship in pediatric endocrinology and her MPH from Indiana University and Purdue University in Indianapolis. And since her fellowship, she's been working in clinical research with a focus on type 1 diabetes prevention and treatments, including new technologies and also in the area of therapies for metabolic bone disease. And she had a bit of a shout out earlier for being one of the founders and sort of developers of the Diabetes Docs program, which was a really successful program, welcoming and supporting those physician scientists who want to study and treat type 1 diabetes. And then we'll go to Dr. Amelia Lindeman. She recently established her research program as an assistant professor at the Herman Wells Center for Pediatric Research at Indiana University School of Medicine. In addition to numerous awards throughout her career, she's currently funded by the prestigious K1 Development Award from the NIH. The primary focus of the Lindeman Laboratory is to understand mechanisms of pancreatic beta cell death and survival, islet compensatory adaptation to cellular stress, and how these factors contribute to diabetes pathogenesis. And last but not least, Dr. William Hagopian. He's an MD, PhD. He's a senior research professor of pediatrics at Indiana University. And his research program studies immunogenic strategies to predict and prevent type 1 diabetes before stage 3, including identification of preventable environmental triggers. His work has identified and validated important biomarkers of T1D risk, and he has then applied them to screening more than 140,000 newborns in Washington state to yield efficient, cost-effective strategies translatable to population-based public health setting and mainstream medicine. We're really excited to have them all here. And the first part of the discussion is going to be biomarker development, challenges and advances, and the role of IU in screening and biomarker development. Sort of where it's been, how it's going, and why IU.
Okay, great. Hey, everybody. I'm just gonna stop sharing. Good deal. Yep. Okay, so thanks, Carmela, for that amazing introduction to our center. Thank you again to Sugar Science and Monica for hosting. This is such an amazing opportunity, and I just want to echo comments that you guys have been such a great addition to our community. And I think we've been really fortunate to have supporters in the diabetes community like the Sugar Science. So I think biomarkers are really important because you really need to have a good idea non-invasively of what's going on at the level of somebody's pancreas, right? And we know in type 1 diabetes, unlike other diseases, we're not so fortunate to kind of be able to get a biopsy and take a snapshot of what's happening at the level of the pancreas. So we really need great non-invasive biomarkers to kind of let us know what's happening with our patients. And so, as I was thinking about this panel and what's the kind of moonshot for diabetes biomarkers, one thing I was reflecting on is that I think we always need to take a step back in type 1 diabetes and kind of pat ourselves on the back for autoantibodies. I think autoantibodies are a great biomarker that's kind of already in place that we're using, and we're using to apply precision care to our patients, right? So we came up with the staging system, and we're kind of diagnosing people with disease before they even have symptoms of disease now. And so I think that's an example of how the research community can come together, make a consensus based on the data that we've accumulated over time and make a change in what's actually happening with patients. And then thinking about what the kind of moonshot next big thing is going to be with biomarkers is I think that all of us appreciate that there's a ton of heterogeneity in terms of even within the kind of established stages of disease, there's a ton of heterogeneity in how quickly people progress and what their individual phenotype of disease looks like. And so, it would be really, really great if we could use some of the tools that we've developed to give us more insights into that. And I would argue that although there are really exciting biomarkers being developed, that our group is working on all the time, I think we're going to hear from everybody about that. We already have some really promising candidates that we could implement. But I think we need to think really critically about translation of those biomarkers and kind of what are the next steps that we need to do that. For example, we know that C-peptide is a really great biomarker that tells us a lot about what's going on at the level of the pancreas. So, are there ways that we could use C-peptide from oral glucose tolerance test data potentially to better inform us about what to expect in the patients that we're seeing? Like, how can we think about really practical ways to use that to guide clinicians who are seeing patients in clinic? I also have been really interested in proinsulin as a biomarker, which is for people who aren't familiar with it, is an immature form of insulin before insulin is, when insulin is initially translated, it's translated in this immature form, which then gets processed. And then when the beta cell gets overwhelmed and stressed out, It'll release more forms of this immature insulin. And so proinsulin can serve as a good readout of beta cell stress and what's happening at the level of the beta cell for some individuals. But, I think there's been really promising data and research, but how do we kind of take it to that next step where it's getting implemented in clinic? And I think we really need to think about kind of working with industry to develop assays that have really established reference ranges in patients with pre-type 1 diabetes or type 1 diabetes, so that we can think about like how that's going to actually get applied in real life as we're kind of thinking about these next level biomarkers. I think other big things with biomarkers are kind of working to put markers together as panels. Like I think most of us think with there being so much heterogeneity in disease, there's not just going to be kind of one beta cell biomarker that's going to tell us everything, right? Probably there needs to also be immune markers that we're putting together with the beta cell markers to give us a kind of more comprehensive view of what's happening. And I think that's going to be really important. And then maybe I'll stop and let other people chime in.
Yeah, no, that's a great overview. And we recently spoke with Anand Hardikar, who's actually on the call earlier this week, about even, sort of the advent of the use of microRNAs as biomarkers. I know that Dr. Hagopian is in the room, and he probably has something to say on this topic. I don't know if he wants to dive in.
Sure. Thank you so much, Monica, for having me. And it's really easy after the wonderful introduction by Emily to talk about this. And I focused on thinking about what might be moonshots as this session is titled, about the things we need to do to translate prediction in the population. And, I think genetics even is there in terms of predictive strategy. You can turn, 90% of new onset type 1 diabetes in kids is not familial, that they don't have an FDR, first degree relative. And so really, if we want to get at that 90% of cases, we really need to take the general population and turn it into a first degree relative like population. And genetics can do that. Genetics is forever. The sample is accessible at birth. And we now have, myself and a lot of others, have panels of SNP genetic variants that we can measure and create a genetic risk score. I think it's been used a lot in Europe and also here in the United States. But what our moonshot really, believe it or not, is to try to make people believe that we're there, that we have it. That we need to make it maybe commercialized, but in any case, widely available. And the little finishing touches, it already works well for different ethnicities, but the little finishing touches we can put on to make it even better for covering populations throughout the world with one homogeneous genetic risk score. I think those are little touches to improve the score, and I think the score will improve over the years even more, but we're already there. So the challenge really of that moonshot is to get it widely appreciated and available.
Well, can I say something about that? I just want to say I totally agree with you. I think like the scores you guys have developed are, they're so useful. I personally have a really hard time understanding HLA genotypes. And so I think it's much easier to understand a risk score. And I think it's something that could be totally clinically translatable, not only before the onset of disease to predict disease, but it's something that could be really useful in taking care of patients who have a clinical diabetes diagnosis. We know so many, especially adults, are misdiagnosed. I think that would be really useful data that we could have in hand that we could take to patients right now,
Do you think that having that data in hand, or that kind of biomarker information in hand for those who are already diagnosed, might help with establishing, if you will, their endotype and their treatment plan? Because it seems that, obviously there are variants in diabetes and within the umbrella of type 1, not outside of it with LOD and so forth.
Yeah, I think it's a great point. The more data we have, the more ability we have to understand that heterogeneity, because I think a little bit of a challenge we all know type 1 diabetes is clinically very heterogeneous, right? But a little bit of the challenge we have is numbers. When something is heterogeneous, right? You need lots of number. And it's type 1 diabetes is a relatively common disease, but it's not as common as something like type 2 diabetes, right? So we don't have the same kind of power to look at these phenotypes. And so the more data we have, the better. And I think genetics definitely could be something that could give us some insights into that.
Yeah. How do you think the situation or the establishment of the testing in Italy is informing your work now? Is it giving you hope that you're going to be able to, I mean, it's a very different medical system, but is it some kind of, how is it informing your work in progress?
I want to make sure I don't talk too much. So maybe we should, Linda, do you want to take that? I think Linda would be a
Sure.
good person to, yeah.
Sure, I can talk a little bit about that. I also want to just like step back before I answer the question, just to say that firstly, thank you for having us here. But then also, I love the idea of moonshots, in part because my mentor, when I came here to IU, always talked about shooting for the stars and maybe landing on the moon. And I went back and I was like, why do you shoot for the stars if you're going to land on the moon? The saying is always the reverse, like you're going to shoot for the moon and maybe you'll end up in the stars. And she's like, no, the stars is like your total aspirational goal, and the moon is kind of where how you get there. So I think what we're talking about in this session is in part these incremental steps, right? These moonshots that then sequentially will get us to the ultimate goal, which is to cure and or prevent type 1 diabetes. So I think that's really important. I think that the work that's going on in Italy and in Israel and also in Canada around population-based screening is really important, because it will allow us access to, as researchers, to a very large population of people that are at risk of or with pre-symptomatic type 1 diabetes, which I think is really important from that setting. It also is a tremendous public health initiative. So speaking of my MPH hat on, we need to prevent ketoacidosis, which we know is bad for long-term metabolic control. We're actively researching, as part of one of the consortiums we're involved with here, neurocognitive development in very young children, and DK at diagnosis is also bad for that. So we want to build on what's being learned there. I do agree, Monica, that it's a very different healthcare setting, a very different place, but I think that the work that Doctors Cherubini and the others in that setting are doing is really, really critical. And I'm very proud that from our center, we have also been involved in some of the work that is informed what they are doing. So some of the consensus we have around how to monitor people that are antibody positive with pre-symptomatic type 1 diabetes is informing the work that they're doing now to monitor the people that are being identified in places like Italy.
Yeah, I agree. I think this is critical, right? And I think screening is so important, and there's multiple ways you can screen, and probably depending on where you are, we're going to have to think about all of the different possibilities, because every country, every state in the United States, the kind of healthcare setup is so different, and the insurance setup is so different, that it's gonna have to be different ways to get to screening the population.
We have a quick question in the chat from Sarah Richardson from Exeter. Do you think staging requires more refinement? Question mark. Potentially factoring age / more detailed genetics. For example, is a young child in stage 2 the same as an adult in stage 2? Should we treat them the same or differently?
This is a great question. I think so I'll say my opinion. You guys can say what you think too, but I think for sure, the stages aren't the end of the story. There's a lot of heterogeneity within the established stages. However, I do think they provide a really simple, straightforward kind of way to consider the idea that you have type 1 diabetes, and you can have a diagnosis of type 1 diabetes before symptoms are present. So that construct is really useful, and I think it's kind of just starting to take hold. And so I think it probably would not be a good idea to kind of change the stages at this point, as we're kind of trying to educate the world and the community about this idea. Like, I would like to see it, in medical schools, medical education texts, that kind of thing first. And then maybe we can start thinking about later kind of changes to refine it. Or maybe it's something that, you think about once someone gets to an endocrinologist, but I think it may be like asking a little bit too much to make it more complicated at this point. But
I'll say we are pushing the needle a little bit with that. So the recent ISPAD consensus guidance, or ISPAD guidelines that are just published now do break down stage 2 and stage 3 into 2A, 2B, 3A, 3B. And Emily, I agree that there needs to be like simplicity around the staging, but I think there are efforts to separate out the people who have overt dysglycemia, and particularly on the other end at 3B, do people require insulin from those that don't require insulin at diagnosis? Because I think that is happening at least a conceptual level that and whether or not and we also talk about stage 0 being single antibody positive, right? So that we're already morphing it, although I do agree that in textbooks I would stick with the definition. I want to make sure Amelia has a chance to speak next to me as well.
Yeah, I just wanted to add, and I think Emily touched on this a little bit with her discussion of pro-insulin, but by the time you have autoantibodies, there is already beta cell autoimmunity, right? And so we know that it takes 2 to tango, right? So that there's a beta cell component in the context of a hyperactive immune system or an immune system that is prone to overreaction, you can develop autoimmunity. So I think that a couple things are going to be key moving forward. One is, can we identify earlier biomarkers? And I think that there's a lot of opportunity to use some of the screening coupled with biobanks to allow us to identify earlier biomarkers that are better predictors for when there will be beta cell dysfunction and when you will start to develop autoantibodies. So I think that there's really a ton of opportunity on that side of things to improve beyond where we already are.
Yeah, can I just add one more thing to biomarkers and I'll let Bill talk too? I just want to say, on the flip side of that, I think as a clinical researcher, I think we need biomarkers to assess where we are successful or unsuccessful with therapies much sooner than C-peptide readouts at 2 years or 1 year, which is the standard of care right now. And I think we're getting there. I mean, there's a real energy around developing platform trials and also having sequential treatments and knowing that, like, I always think about the PSA for prostate cancer. So you can monitor that and you can know that it's time to do the next thing if your PSA rises. Again, we need more markers like that, and it'll come out of all these different spaces. And I think that that's going to be really important to innovate on clinical trial design. With that, I'll turn it over to Bill again.
Thanks. So, in answering the question that was asked, the transition from stage 1 to 2 and from stage 2 to 3, I mean, we'd like to know a little bit more about how to follow that. And I look at heterogeneity from the point of view of the biomarker. So it turns out that there's a bunch of glycemic tests we can do. We can do a hemoglobin A1C, we can do an OGTT, we can do a mixed meal tolerance test, we can do a CGM monitor. There's lots of things we can do. And I think it needs to be sorted out how we might use these things, maybe in a sequential way, like hemoglobin A1C, and when that becomes abnormal, then CGM, or then OGTT, but that needs to be sorted out. And at the same time, this stage 1 to 2 to 3 transition, the other people in the room, Emily and Amelia, and all of our beta cell physiologists know that the peripheral bloods, proinsulin and insulin C-peptide and all, will reflect sort of the beta cell status. And that really may help in those early stages as well. So those are kind of the 2 global areas that we need to moonshot in order to make that following of transition through the stages. I'll also say that the progression in very, very young versus older people is kind of the same. It's faster in the very, very young. So in some cases, we need to really think outside of the box and how to follow that progression in the very young, because it occurs so quickly. We need to test maybe more frequently and with simpler tests because they need to be covered as well.
Just a shout out to Jack Verosco and his imaging studies. I see he's in the room. If it would be fantastic if there was some way to really follow the imaging of the youngest patients to really see if the smaller pancreas and that kind of pathology interfaces with that faster progression. Just a little sidebar, but also just one last thing before we head into the clinical trials and tech screening initiatives. We've got 2 here. One is follow on for Bill. What is the pathway to increase the use of GRS to find the 90%? What evidence is needed to use it outside of clinical trials? What numbers are needed for regulatory submission?
Well, I think that, that if you want to think about a minimal strategy that can meet a cost-effectiveness barrier, I think you need to think about genetic screening followed by sparse autoantibody surveillance of the population of kids. So that needs to be trialed together to show that high genetic risk scores catch most of those early cases, and the early cases can be caught mostly with this sparse antibody testing. And that really, it's just that if the genetics is sensitive enough to actually catch most of the early cases, then I think we're home. And there are a number of trials on, currently underway that are testing that. And once it's done, I think it can be implicated. But I should also say that, we need to think outside of the box with respect to the antibody testing. The antibody testing doesn't have to be in a clinician's office during normal child care. It can be, a mail-based kit. It can be, there's very little volume of blood that's necessary now. And we have to think about ways to get the vast majority of these kids with high genetic risk, maybe 20% of the population, a huge burden for sampling. We need to think about ways to do that. And that would be kind of another moonshot idea as to how to translate that to everybody, 20% of the pediatric population getting sampled during their early childhood for antibodies.
That sounds like a plan. Okay, so in the interest of time, let's move into our second topic, which is the clinical trials and tech. So screening initiatives, challenges and advances. What's the role of IU in this space? And I think, let's see if we could start off maybe again with Emily.
Okay, sorry guys, I've been sick, so I've been eating cough drops, so I'm not just chewing gum. And okay, so screening is something that IU is very, very passionate about. Linda DeMeglio for years has had at our TrialNet Center, so we've had experience with screening in family members. But I think, as Linda mentioned, we know that there's benefit for screening beyond family members because 90% of people who present with new type 1 diabetes don't have a family history or a known family history. And so, if we really want to benefit the most people from screening, it's good to think about ways to screen everybody. And so I do think as low-hanging fruit, we should be targeting family members. So we do this now, but I think everybody should be thinking about this in clinical care because, we know we have good benefits to identifying somebody in the pre-symptomatic stages of disease. I think part of standard of care, people who are family members of people with type 1 diabetes should be offered the opportunity to screen their family if that's something that's the kind of right decision for them. For general population screening, actually, we've been kind of brainstorming about creative ideas to do this, to implement general population screening. And what we've kind of landed on is we're working with our local biobank to try to start screening here. So we're working on a project where our biobank does testing or does blood collections and genetic testing in a kind of large group of people already. And so wouldn't it be great to take advantage of those genetics that are kind of already there and kind of do an approach like Bill was talking about to screening where we enhance for people who have the highest genetic risk and then do autoantibody screening on those individuals. And so we're kind of piloting that now, looking in the EMR to see if that's going to be an effective approach as another alternative to implement screening in a sustainable way. So that's what I'll say about screening. Yeah.
All right. Do you want to expand that into clinical trials coming out of IU, Linda?
So sure. So we are very engaged in a variety of clinical trials, ranging from working to identify people at risk and then enroll them into trials at that stage. So we worked, as was noted, earlier with the studies of teplizumab in that space. We're involved with studies in ATG in that space, oral insulin, hydroxychloroquine, a variety of different places there. We also are very actively involved in beta cell preservation, which is in the new onset space or recent onset space. And there we have currently open 4 or 5 different trials trying different approaches in that setting, including studies of rituximab, of DFMO, as was mentioned by Carmela earlier, rituximab, DFMO. I'm not going to remember them all if I try to name them all. Denosumab is one. Dr. Ismail, who I saw on the call, who is going to speak later, is also looking at prebiotics as a way of modulating the microbiome in recent onset type 1 diabetes. So there's a whole variety in that space. And then the other part of that, I think, is really, even if we succeed with all of our moonshots in these various areas, there's still a need to also improve quality of life and improve care for people that are living with diabetes. So we have a number of investigators that are working on clinical trials work around technology and new therapeutics. We've done new insulins. We've worked with new pumps and sensors. We were very instrumental in the approval of nasal glucagon and other forms of soluble liquid glucagon. So I think that's been great. And there, another name I want to highlight at our center that's not been mentioned yet today is Viral Shah, who's an adult endocrinologist who's joined us recently, who's doing a lot of novel work in that space as well. So I think each of these kind of pillars within the clinical trials, the prevention pillars, the preservation pillars, and the technology therapeutic pillar is really, I think, critical for making progress and for informing care and, you know, moving closer to cures and better treatments.
Great,
I-
thank you for
sorry,
that
can I say-
flyover. There's so much to talk about at IU. It's amazing.
Yeah, I was just gonna add into the trials. Like, I think a thing that we obviously have a lot of interest in, and so I'm really excited about is this idea of disease modification. Because to me, this has felt like something that's been a long time coming, but like I really have felt the needle shifting on this paradigm recently, with the FDA approval of teplizumab. And I think people have been really excited about teplizumab, right? But all of us in the field don't feel like teplizumab is the final answer, right? Like it's just us getting our foot in the door. But this is really a change in the paradigm of how we're taking care of this disease. This idea that we're kind of modifying the underlying process so that people can make more of their own insulin, right? And using disease modification. And I think, life is better if you have your own beta cells. Like life is better if you're making your own insulin in type 1 diabetes, even if we're having to give insulin back. And so I think it's really, really critical. And it's really a paradigm shift. And I think it's going to be important for endocrinologists to kind of start embracing this paradigm shift too. And so that's a thing we've been working on locally. And I think it's a movement that's happening, across the world slowly. But I think that's going to be a really important thing. And so another thing we've been doing is these trials kind of, I think combination therapy, I know a lot of people feel like this, right, is going to be the ultimate approach, but thinking about other mechanisms. And a piece of our center is this idea, as Amelia alluded to before, that, there's this kind of deleterious bidirectional dialogue that's happening between the beta cells and the immune system. And so we've really been big champions for other kinds of therapeutics, specifically that target the beta cells. So Carmela Evans-Molina actually is the leader of the TrialNet Jackpot study, which is testing two JAK inhibitors, which are really, really promising agents. There was the Bandit study in Australia published, I think it was a year ago, that showed an effect in new onset type 1 diabetes, but it's really promising because that pathway is active within immune cells, but also within beta cells. So it's kind of a double hit to that pathology that's happening in type 1 diabetes. And then Linda and I, as mentioned, lead this trial called TADPOL, which studies a drug called DFMO, which is meant to target, again, the kind of beta cell stress pathway that gets activated during the kind of bad inflammation that's happening at the level of the islet in type 1 diabetes. So I think there's some really exciting trials happening for agents that you could use in combination with drugs like teplizumab as well.
Are there opportunities for sort of like incoming trainees and incoming MD, PhDs, and MDs to participate, in certain levels of these trials? Are you open to collaborations with these trials? It does seem that way, but can you just kind of like unpack that a little bit?
Yeah, I mean, that's the funnest part about what we're doing, right? To me, this is the thing that makes this so much fun. Like I have to pinch myself that we get to work on these exciting things, but we always love to work with trainees because, they're the future. They're the ones who have all the best ideas that are kind of really changing the way we think about things. We're always storing samples from studies. So I think definitely like people should contact us we're always interested in new mechanistic studies. And I think biomarkers are always something that, trials like you can ask interesting questions with. So I'm always open to new ideas about that as well.
I think it's a known fact that IU is open to collaborative, endeavors. And so it was nice for you to sort of just tap on that. Thank you. Let's just, at the end of the day, it's really kind of like, what's the mechanism? Let's talk a little bit about the mechanism and basic science around these two parts of type 1 diabetes, the beta cell dysfunction and the immune response, and the mechanism that's informing clinical translation. So let's have Amelia Linneman open that up for us.
Sure. So, I feel very strongly that the discoveries we make at the basic science side of things are only as good as their translatability. And, so key to that, and this is kind of what I've been thinking about as my diabetes moonshot, I think key to that is ensuring that we have relevant models, right? So, we all know that a beta cell sits in an islet and it's surrounded by other cells, and there's vascularization and there's innervation. And, so when you take a beta cell out and you study it on its own, how relevant is that actually? I recognize, I guess practically that many of the approaches that we use are not amenable to an islet in its niche. But I think that is really a challenge for us that we need to think about. And we need to think about what are ways in which we can advance the technology to really study function in a relevant way. So, how do we study a beta cell within an islet? How do we study its function? How do we understand normal physiology, which I think is really key to understanding pathophysiology? And honestly, we really don't know how a beta cell truly functions, at a mechanistic level in response to stress, in response to an overactive immune system, and how does that dialogue occur? And so I think that there is a ton of opportunity for growth there, but really we need to be working together. I mean, coming back to this collaboration, I know that this collaboration aspect. So I know that there are, many people working on trying to develop models of autoimmunity against human beta cells. And, people way smarter than me that are working on this, but, you can't be an expert in everything. And I think this is where we need to get out of our silos. We need to be thinking about how we can work together to solve some of these problems. One of the ways that we're working on that is through imaging. So I as Carmela mentioned earlier, I run the microscopy core for our diabetes center. And something that we've worked really hard on is developing methods to study and to really visualize beta cells in their endogenous niche. And one of the areas which we're really trying to develop is to not only look at the beta cells and how they function, which is kind of a low throughput approach to doing it, but to be able to couple together, all these technologies that are coming through the pipeline so that we can take the same islet and identify as much as possible about it, as much as possible about the immune cells that are in the area, and then to correlate that with systems. So that's an area where I think that we are making good progress. We have a fantastic team of people here. People that we haven't discussed yet. Jason Spaeth is really interested in pancreas development. Also, Teresa Mastracci, who's over on our other campus, who is studying, beta cell or islet exocrine interactions. I think we're going to hear from a number of people, but John Piganelli, who we recently recruited, who's studying the immune system. We've also got the Indiana Biosciences Research Institute right downstairs from us, with a number of people that are truly experts in what they do. And I think that our collaborative spirit is really what's going to help us to drive forward, some of these interactions so that we can solve some of the problems.
Absolutely. And what Amelia said about the beta cell physiology needs to be translated to taking a peripheral blood sample and being able to measure that. And I think at Indiana, we have the basic scientists working on the beta cells in the islets, and we have the clinicians working on trials and prediction and identifying early stage. And that's a great combination. I think I'm very excited.
Yeah, I've literally taken blood from a patient on the unit. And brought it and dropped it off at the research center on a Tuesday and then been in a lab on the Friday when people talked about results from what we had there. So it's just like we have that ability to do everything from population health all the way through to basic, very basic island specific work. So it's a phenomenal environment to get that stuff done.
Yeah, I think that's especially important because we know there are so many differences between our mouse models and human type 1 diabetes, right? I personally am not like so negative about the NOD mouse. Like I think it's not going anywhere. It's given us a lot of really important lessons, but also we know there are kind of key differences with human physiology. So really important to make sure we have ways to study human tissues like in these important contexts.
Yeah, to recapitulate findings in mouse, and you at Indiana have a very strong pipeline to do that. It's very obvious. We are at 10:51. I'd like to open it up. There's been several questions, so I'd like to open it up to some questions from people in the audience, and we have quite an international audience as well. Anand Hardikar from Sydney, would you like to unmute yourself and ask your question to the panel?
Right. Okay. I think that's fantastic. I've always enjoyed talks from Emily and Carmela and others. One of the things that we have been trying to work with Richard as well as others in the field. I mean, GRS has gone a long way. It's the first biomarker that you can measure when someone's born, and that's absolutely fantastic. But one of the key I don't know, it's a strength as well as a limitation, kind of, that the risk score kind of stays the same across lifetime. So one of the things that we have been working, and it's not published, but what we are excited about is these dynamic risk scores, which can be microRNAs. I mean, Emily mentioned glucose, C-peptide, proinsulin. I mean, there's so many of these biochemical, but we are looking at some of the molecular dynamic biomarkers. Age can be also age of collection was an important variable in our study. But what do you think about what I think would be really interesting and exciting is to bridge a combined risk score using the genetic risk score and then building the dynamic risk scores on top of these, because we have an older version of the preprint on Research Square, but the newer manuscript is gone for review now, but we'll see how that goes. But I presented that in the last session of Sugar Science, and we are pleased to see that the predictions hold even after doubling the validation set size. So we are very excited to try and see how this could kind of be bridged between the GRS and the dynamic risk score that we have been working on. So any thoughts what you think about these kind of dynamic biomarkers?
Yeah, I mean, I think that kind of approach makes a lot of sense. Like, especially like if you think about the pathophysiology of type 1 diabetes, right? Like we know there's kind of a constant component there of risk, right? But then there's also environmental pieces that affect your risk too, that are dynamic. So I think a combination of markers like that makes a lot of sense. I think Bill wants to.
Bill's got some things to say here.
So what we did in Teddy is actually we were looking for viral triggers, and so we did really frequent testing, right? And when you do that, you can actually then understand how you can make the testing more sparse and still get to the answer that you're interested in. And I think the very important thing is how to translate this testing into the real world, into the clinic, and do it efficiently and cost effectively. And so for that, I think it's really important to do very frequent sampling in a research study and to refine that. Those markers are really, really great. And I should point out again that it's the very young kids that progress so quickly that and they have worse pathology at onset of stage 3 type 1 diabetes. They often don't get their antibodies until 2 weeks before they get their hyperglycemia, okay? And we really need something there. One more thing that I want to mention, nobody's mentioned biomarkers of viral infection, which might be a very important thing to add to the mix. I'll leave it at that.
Anyone want to weigh in on viral? Sorry, looking to see if anyone's dropping in the chat here.
There's one thing while people are thinking about that, the other thing I think that we haven't talked about yet, although we've talked about screening the general population, is that the other advance, I think, in this setting is knowing that the tools that we use in these various cohorts can apply to general population settings. That's part of what's going back to the general population screening of antibodies, which is a different way to identify people at risk or with early stage diabetes. But I think that knowledge over time, that what we're learning from cohort studies and from studies in people that are relatives or people identified from birth, like those, they're concordant. We're figuring out, I mean, there's slight differences. And that's part of why I like in TrialNet now, you know, if people are identified as non-relatives but have antibodies, they can come into clinical trials, because firstly, it's really important to study that group, but secondly, we know that I would say that a need that we have, so we've talked a lot appropriately about moonshots, but also not really yet address the gaps that still remain, is really to start validating what we're doing in other populations, so much more diverse populations, other groups of individuals. Most of the data we have comes from white populations, from westernized countries, those sorts of things. So I think we need to see how it's applicable in other settings, although we expect it will be. I think it's important because there may be differences in how we need to screen, what biomarkers are appropriate, what we do by just differences in that setting. So we just hadn't talked about those things, but we can come back to viruses. But while we had a moment, I thought I'd just raise those as things we've not talked about yet.
Yes, the PSA for heterogeneity and its importance. It's good. I think, oh, sorry.
Sorry, I was just going to add, you know, we published something around this with Maria Craig and others about microRNAs that change in response to viral infection. But I know there's a lot of other kind of literature related to viruses and multiple dynamic biomarkers. I mean, the interest that we have in microRNAs is just because they are regulatory in nature, so can actually, and just going back to the point again, I'm not kind of self-advocating, but just interesting to see that also
Oops, someone's
about, please, about.
not
Okay.
sure what happened there.
Sorry, I was just going to say one sentence that what we find interesting is we can use these to, at the study baseline, to identify progressors and non-progressors, or identify those who are responders to the therapy versus non-responders. So that's really exciting.
A question, thank you for that. A question from Kiara Gerda, who's now at Wisconsin. She's saying the heterogeneity in T1D population, particularly due to genetic variation, significant challenge. How are you approaching its complexity to tailor treatments or interventions more effectively for these different subgroups that you're talking about within this population? You did mention prebiotics for the intervention. Any plan to include gut microbiome or metabolites as biomarkers? I think that was touched on a little bit earlier.
Yeah, I think Hibba will talk more about that in her session later. I think yeah, I think that's important. I think we are just really slowly starting to gate some of our clinical trials by some of these markers. So doing some specific things by HLA, those sorts of things. I think as was just mentioned, I think looking at responders and non-responders in trials is often the way we've done it, because we bring in all comers and we have them try the therapy, and then we look at who had succeeded, and that can allow us to gate things further. But I think just like we're dipping our toe into combinations, I think we're starting to consider that as we look at entry criteria into trials. Like one of the things Emily and I've talked about with DFMO is if it's a drug that decreases beta cell stress, should we really be studying it in people who demonstrate higher beta cell stress rather than in all comers? Because we know that although on average that stress is high, not everybody has the same measurable marker of stress, or should be done in somebody with different genetics or different. I think that's going to be the next stage of these trials, as well as once they're in the trial, then looking at a marker to say, okay, is it succeeding and do we need to switch out? But people are starting to think about that. Those kinds of trials, like the GAD trials, which have really a really focus in, are hard to recruit for, because as was mentioned, it's a relatively common but yet relatively rare disease. And so some of those types of trials they just take a while to get if you gate up front. So, but in some cases, it's very, very important that we do that.
Yeah, the other interesting thing I was going to say about that is we were part of this big precision medicine international initiative, the prevention group. And Jamie Felton actually led a group on T1D prevention and precision approaches. And, you know, we were really surprised to see that a lot of the analyses looking at precision responses to therapy and trials for type 1 diabetes were post hoc analyses. So I think, you know, as a field, like if we really, really want to support this idea, you know, even if it's a study where we're doing kind of a sub-analysis based on some kind of feature, we need to kind of pre-specify the hypothesis and just to kind of lend more credence to those analyses so they're, you know, a little bit more statistically rigorous. And like Linda said, it's just, it's challenging because of numbers, right? Like it's hard for us to do a prevention trial just by itself, right? Like when you're taking everybody. So we need to screen more people so we can do more of these studies. And
perhaps the next visit to IU will be just screening, talking about screening and sort of digging into solutions there just alone, because that itself could take another hour. I don't want to cut anybody off, but in the interest of everybody's time, we so appreciate all of your talk. This group is really just the tip of the iceberg of talent at IU. You can see just from the breadth and depth of their experience and research expertise, as well as the initiatives that they are pursuing, you know, very strongly. They have this incredible pipeline there. They have Dr. Carmela Evans-Molina at the helm, who frankly, I don't even know how she gets 1 hour of sleep a night, since she seems, you know, she's just doing so many things simultaneously. So it's just an incredible place to do science and in clinical research in type 1 diabetes. I would encourage all potential collaborators and trainees to look carefully at the opportunities there and reach out if you need more information. And also, we will be hosting individual interviews with the trainees and early career scientists mentioned earlier, and we'll have those hosted up on a full page devoted to IUMC. So we hope that you'll, you know, if you'd missed it here, you can listen after the fact, and we know you do because we see that we have a lot of people listening, perhaps when they're in tissue culture or riding their bike home or whatever they're doing, they're listening and they're watching and they're very interested in you know, sort of scientists talking to scientists and discussions that we're hosting. So thank you all very much for your time, your expertise, and your energy that's devoted towards pushing this further understanding of type 1 diabetes further towards a cure.
Thank you.
Thank you, Monica.
Thanks again to everyone who participated, and have a great rest of your day. Bye-bye for now.